Excellent. Well, good evening, everybody. Thank you so much for joining us tonight. We have a very special program, Ask Me Anything, long-term side effects of cancer treatment. And we've gotten a lot of really great questions tonight that have come in advance of the meeting, but please feel free to ask questions of our special guest tonight by putting the questions in the chat box, and then I will ask them of the doctors so that we don't have too many voices overlapping during the session. This session is being recorded, just so you know, and will be featured on the SHARE website within 1 to 2 weeks. And now it is my pleasure to introduce Dr. Stan and Dr. Zelnak. Dr. Stan is a physician with the Mayo Clinic in Rochester, Minnesota. She has particular interest in breast disease and issues relating to breast cancer survivorship and symptom control. Dr. Zelnak is a board-certified hematologist and medical oncologist with Northside Hospital and Atlanta Cancer Care in Atlanta, Georgia. And she happens to be my oncologist, so I'm very happy to have her here. And I'm very happy to have all of you guys on the line. So I'm going to kick things off with questions. We have a bunch of questions. We have a bunch of attendees tonight. And so I'm going to kick things right off, and then we will endeavor to end right at 7 as usual. So first question about treatment. What is the standard of care for early stage triple negative breast cancer? And should every patient have a similar standard of care?
I think that's me, right?
I think so, yeah.
I think so. So, well, thank you everyone for being here tonight. Appreciate it. So just to dive right in with early stage triple negative breast cancer, most of these patients I think are getting referred for preoperative chemotherapy now, just because that's going to be part of their treatment to prevent recurrence. So typically for patients that have palpable tumors, or really tumors once they get close to 2 centimeters, or lymph node positive disease, would come meet someone like me before they have surgery. And I think the chemotherapy landscape for those patients has shifted over the past, really, I would say even the past couple months. It used to be that the standard in the preoperative setting would be to get a combination of anthracycline-based chemotherapy followed by a taxane. And then a couple years ago, we started adding in carboplatin to the patients that had more locally advanced disease or even just lymph node positive disease. And then just a couple months ago, the FDA has now approved the addition of pembrolizumab, which is immune therapy, to kind of the standard anthracycline and taxane-based backbone. So I think one of the big questions that we have in the clinic is, well, who needs the whole intense treatment versus are there some patients where they can maybe have less, a shorter course of chemotherapy? So I think working with a medical oncologist to figure out, do you need just AC followed by T? Do you need AC carbo T, or do you need carbo T, pembrolizumab plus the whole shebang, right? So, I mean, I think that's really where things are. And certainly if you do have your surgery first, we'd then give similar chemotherapy in the postoperative setting. But at this time, there's not any indication for pembrolizumab in the adjuvant setting. That data is still forthcoming with a large clinical trial that's been looking at pembro in that setting as well. Is that good, Nancy, or you need more?
No, that's great. I think that's great.
But I think, yes, of course, people should get standard of care.
Yeah.
Right. I'm all about the business of giving people standard chemo. I think certainly if you've got comorbidities or you're older, you may need to think through how intense is your chemotherapy going to be. But I think, for most of the patients with early stage disease, the goal is for cure. And so potentially being more aggressive with the chemotherapy can be helpful.
Yeah, excellent. Okay. And if anybody has follow-up questions for either Dr. Zelnak or Dr. Stan as we go, please just put them in the chat and I'll keep an eye on those. What can I do to deal with possible side effects that may develop later after treatments have stopped? So side effects that perhaps we don't even know about.
Maybe I can interject here, since I deal mainly with survivors from breast cancer. So I think a lot of the side effects are related to the chemotherapy, some with radiation, so pain in the breast, things like that. So I think just being proactive about it, bringing up to your doctor, of course, seeing your doctor every 3 to 6 months for the first few years is recommended, and or your provider, a nurse practitioner. It's important to do a breast exam to see how your shoulder range of motion is, see what we can do about that, if it needs to be fixed, and then, of course, addressing the side effects of chemotherapy, which are many, and we can talk about them, but the neuropathy, the potential heart problems that occur with the anthracyclines, potential brain fog, all that. And it seems that sometimes early intervention is essential, but I think one of the important things that everybody has to think about, because it seems to help with many of these symptoms, is lifestyle, the regular exercise, the diet, keeping a healthy weight, thinking about mindfulness and things like that are all important in survivorship and seems to help with all these symptoms. So an overall approach to the whole person that includes medication intervention, but also mindfulness and holistic type of an approach to care.
Great, thank you. Dr. Zelnak, you touched on this a little bit, but I'm hoping you can expand on it slightly. What immunotherapy drugs are approved for the treatment of early stage, which you talked about, and then metastatic triple-negative breast cancer?
Sure. So we talked some about the pembrolizumab, which is currently approved for neoadjuvant chemotherapy. And it's interesting, you get the pembro throughout the chemotherapy, and then you actually continue it for close to basically a year. So you do some with the chemo, and then you continue it afterwards. In the metastatic setting, initially atezolizumab was approved, but the FDA just withdrew their indication back in the late summer. They had initially shown positive data in one study and got accelerated approval. And then the subsequent follow-up trial that was supposed to confirm it was not positive. And so that FDA indication for atezo just got withdrawn. But that being said, pembro also has now gotten approved in the metastatic setting because their one trial was positive, or they've had several, but the registration study was positive. And the pembro in the metastatic setting is approved for patients that are PD-L1 positive, and about, I don't know, call it about 40% or so of metastatic triple-negative breast cancer patients are going to be PD-L1 positive. So if you have PD-L1 positivity, you typically would add the pembro in to first-line treatment. And the study was set up where they had a couple different treatment arms. So some patients were getting paclitaxel or Taxol, some were getting nab-paclitaxel, which is called Abraxane, and then there were other patients that were getting the Gem-Carbo regimen. So there's a little bit more flexibility with that approval. But that's the main drug. Of note, there are not any immune therapy drugs that are approved for HER2 positive or ER positive, HER2 negative breast cancer. So the indication is strictly for the triple negatives.
Got it. And then is PD-L1 a genetic marker?
We typically order it on the tumor. So it's part of, like, when we send off genomic profiling on a tumor, typically that'll come with either your foundation testing or Caris or whichever one your doctor chooses to use. It's available with that. You can also send it as a standalone test. But I think, again, patients are typically having that done now as part of their initial, when they're first presenting. Before we used to wait, I think later on, to send the genomic profiling on our breast cancer patients in the metastatic setting. And I think we're now routinely doing it early, just because it impacts, are you eligible for a PARP inhibitor if you've got a BRCA1 mutation, or is there some other actionable mutation that you see? But then specifically with the PD-L1 testing too, it impacts your care. So it's important to get that information. Yeah.
Yeah, definitely. Peripheral neuropathy, does that last forever, or is there sometimes an end point to that?
Oh, I don't know. Dr. Stan mentioned it earlier. I will tell you, peripheral neuropathy, when I think through the long-term complications from chemotherapy that patients have, again, the fatigue can be tough. The side effects from chemotherapy-induced menopause for patients are tough. The aromatase inhibitor side effects that are the menopause ones, but the peripheral neuropathy can just be really, really debilitating. And it often happens during the chemotherapy, and there's just not a lot of data around ways to prevent it. You know, and the reality is that not everyone gets it, right? So it's really hard to do studies too. It's one thing to say, I'm going to do a trial to see if we're going to keep your hair from falling out, right? Because 100% of people are going to lose their hair. And so you can then assess, did what I do prevent or not? But with the peripheral neuropathy, when many people don't get it, it's hard to then assess, did this intervention really impact stuff? So, you know, I think during patients' treatment, I tend to focus a lot on, well, what anecdotal data do we have? So patients often take B vitamins. I've got patients using glutamine powder. I've got patients using these ice hands. You know, that's a new thing. I mean, again, I don't know if it works or not. I don't think it's harmful to ice down your hands with these gloves, but you know, that's the time when you really are going to be able to make some impact on the prevention of it, because once it develops, you know, yes, it does get better over time. But at some point, sorry, my lights just went off. That's what happens when you don't move in the room. At some point, you know, it may be as good as it's going to get. And then you're left, you know, trying to manage by taking, you know, medications like gabapentin or Lyrica, or seeing the physical therapist to see if they can help you kind of cope. You know, and patients do all sorts of things, but I think you'd be much better off if you could just prevent it.
Yeah.
I agree. And also I'm seeing them later on when it's already established, and it usually gets better. I want to say we do use medication intervention. One of the favorite out here, because it was studied here, is duloxetine, an antidepressant. So we use that. Other potential topical medications such as capsaicin or menthol topically. Exercise seems to help with that as well. Muscle strengthening and balance type of exercises seems to help. And we also have a machine called a scrambler that was studied here, and we use it, and we have anecdotally some good results with that. So different ways of approaching it. I know it's a big issue and very common, and yeah, I think it gets better over time, but some people remain with it for a long time, unfortunately.
Yeah, and what about neuropathy to the point where it's causing quality of life issues? Do you have any kind of thoughts or recommendations on what somebody might be able to do to improve quality of life there?
Again, I would say physical therapy, exercising, all these medications. That's pretty much the only interventions I know about.
And I get anecdotes from the patients. I had somebody recently tell me, you know, one of the classic symptoms is just having the sheets touch your feet, you know, at night, and the bed just wakes you up. And that then leads to fatigue because they're not sleeping well. So I had a patient who she bought socks that had individual toes. Do you know what I mean? Because somehow her toes touching each other was causing problems. And I mean, so sometimes simple things can help. But, you know, again, I think the medication management becomes important, you know, focusing on how you can best control your symptoms. If it's interfering with your daily activities, it's incredibly frustrating, right? You're potentially cured of your breast cancer, but have a long-term impact on your quality of life, which is just, you know, really hard.
Yeah. Thank you. I'm going to ask, excuse me, my question that I submitted. So my main long-term side effect is chemo brain. I'll find that I have a word on the tip of my tongue and I just can't get it out. And it's frustrating in social situations. It's frustrating at work, especially when people don't know what's happening. Have either of you had patients with a kind of similar long-term side effect, and any recommendations on what might be able to be done to manage that?
I'll jump in. Yeah. People do complain of this side effect. Again, I notice it gets better over time. We do some intervention. We have neuropsychologists here that can assess the function, cognitive function, intellectual function, and then they can intervene with some advice on where to focus, how to keep track of things, how to make lists, how to make reminders. Again, some interventions that are out there in the literature, and we do try to send the patients to our integrative medicine for some mindfulness training. There are some recommendation about some biofeedback with EEG that you can learn how to relax your brain, and that seems to help in some studies. exercise is important, sometimes stimulants for very severe impact on quality of life. We may use the modafinil or the methylphenidate. Those are stimulants that might help with it.
Thank you.
I think one other thing that I tend to focus on with patients is just sleep. Because often the fatigue that comes with sleep can, lack of sleep can be really important. And many patients, particularly younger patients that have chemotherapy-induced menopause with lots of hot flashes and night sweats, can have that kind of materially impact their sleep quality, which then I think affects the what we call mental acuity, right? The decreased mental acuity. But the exercise is huge. I think there was just a study recently talking about how exercise during chemotherapy, has been shown to help improve kind of that subjective brain fog that people get, which again, that's where potentially preventing it from even getting, to be as severe during the chemotherapy portion can then help you later on.
Interesting. Okay, so here's another question. My cancer was estrogen receptor positive. Why do I need to take an estrogen blocker when I've had a complete hysterectomy and I'm 75 years old?
Sure, I get asked this question a lot. So even men have a little bit of estrogen. So that's the answer, right? So even men with breast cancer take tamoxifen or a hormone blocker in the adjuvant setting. So for premenopausal women, the bulk of estrogen is made in the ovaries, but you still have some estrogen that's made primarily in the fat tissue, but in other tissues. So some of the adrenal hormones get converted into estrogen. So even just that small, slow trickle of estrogen can be enough to stimulate cancer cells to grow that are hormone sensitive, which is the rationale for women, even postmenopausal, and men to take the hormone blockers in that setting.
Interesting. Okay, what testing is currently done to determine if cancer has spread?
Is this me?
I think so.
Yeah, so for early stage breast cancer, I get asked this question all the time. How do I know I'm okay? All the time. And the reality is that the current NCCN guidelines recommend scanning for symptoms, which means as long as you don't have any worrisome symptoms for spread of your cancer, you don't need a routine CT scan or PET CT or bone scan. That being said, if you do have symptoms that are worrisome, you need to go talk with your doctor about it and have it worked up. So, that's one of the main things I do when my patients are coming back for their regular follow-up is just run through a list of questions. And I'm not even sure patients realize what I'm asking, right? Are you having any bone pain, any breathing trouble, any stomach trouble? Going through that list. And if there's anything, you're going to work it up. But the recurrence rates for early stage breast cancer are really quite low. And the vast majority of patients do really well. So you're really looking for those patients where there's likely going to be something wrong. There's a lot of controversy about how frequently do I need lab work and things like that. And again, the guidelines recommend once a year labs. They currently do not recommend that we check tumor markers, although I know a lot of clinicians still use them. Certainly in the metastatic setting, I think many people use them. In the early stage setting, the testing that we currently have that's standard of that you could just order, off the shelf, so to speak, is really not all that reliable. So in clinical practice, those tumor markers often are either falsely high or falsely low. So they can be misleading. So, I don't typically order them, but certainly I have colleagues that do. I don't know, Dr. Stan, how are you up at Mayo? Do they, it varies, yeah.
As well, we go by the guidelines from the NCCN and the American Cancer Society that, just like you said, they do not recommend routine imaging except for people who have symptoms. So exactly the same thing. We ask about potential symptoms of recurrence, and if there is any, then we do a focused image like a bone scan or a CAT scan of the chest. If it's a cough or something like that, we don't do blood work routinely or tumor markers at all. I would just say that maybe with the triple negative, from my review of the literature, it seems that the risk of recurrence goes down after 6 to 7 years if they have a low risk of distal recurrence. I don't know how you see that.
Yes, the vast majority of recurrences for those patients would have already happened by 5 years, to the point where I think it's appropriate to either have those patients 6, 7 years out be referred back to primary care, as long as they've got someone that they're comfortable with, or just come back annually. The one thing I didn't emphasize, for early stage patients, you absolutely need to keep doing your breast imaging, right? So that's a separate topic, right? The mammograms or the MRIs or those types of things. There you're screening for a second cancer, or a local recurrence. That's a different type of screening test, right? That of course you should continue to do, versus scanning for distant metastasis, which would not be recommended routinely.
Got it. Thank you. Dr. Stan, I think that this one is for you. A few questions came in about pain following radiation. Is pain common after radiation? And what's the best course of action for patients to alleviate that pain post-radiation?
Yeah, I find that it's a very common symptoms. Most people would have mild symptoms of pain. It's both in the chest wall and the breast tissue per se. So depending on where that pain is more significant on the clinical, when I do the examination, if I feel it's a chest wall pain, I counsel them about wearing a good bra without underwires, wearing a bra at night. If the breasts are asymmetrical after radiation and surgery, I give them a prescription for a bra with an insert that can equalize the bras. And it seems that the support helps a lot, just supporting the breast, because you don't have the breast pulling on the chest wall that way. And that helps with the breast pain as well. Some people have some degree of breast lymphedema from the radiation and the surgery, with the interruption in the axillary lymph nodes in the armpit. So those people in which I see there is swelling in the skin, the skin is thickened. It's in a way like an orange peel, but pale. I send them to the physical therapy in the lymphedema clinic, and they are very good about showing them massaging techniques to deviate that fluid to the other breast or to the back. And there are compressive bras that we use. Yeah, I rarely use medication. Maybe sometimes I do a lidocaine patch, things like that, but rarely have to use any medication that you would take orally. Yeah, I think supportive care is the mainstay. And of course, if there is fluid collection, I may involve my surgeons to see if anything can be removed, or the radiologist to aspirate, especially immediately from surgery. But it is common. It is treatable though. And I see people get a lot of help from just those local manipulation of the tissue and support.
Got it. And how long do you see that last post-radiation?
Many years, unfortunately.
Yeah.
I even see it, 10 years later, 15. I don't feel it interferes with the quality of life a lot. Not many people say I can't do anything because of this. It's more of a nuisance.
Yeah, I put it in the annoying category, right?
Yeah.
Yeah.
Annoying, but not usually life-altering.
Right.
Yeah.
Right.
And here's one kind of along similar veins. So I have shooting pain at my surgical site occasionally, and it's years past surgery. Do you see other patients that experience that, or any kind of thoughts on that?
Absolutely. Yeah, that's exactly the symptom of the chest wall inflammation. So sometimes I send patients to acupuncture. We had some success with that, or massage, and just gentle care to the chest wall, heat, cold, things like that seems to help. And don't wear underwire bras. Bra at night seems to be helpful.
Yeah. Okay, so how best to distinguish what concerns or issues you should contact your primary care physician over versus your oncology team?
I mean, I think this is, I think a lot of patients ask this question, right? I think certainly from my standpoint, where is breast cancer most likely to return? Is most likely the liver, lungs, and bones, probably bones highest and then liver, lungs. So certainly if you have any new aches and pains like bone pain that you just don't have a good explanation for, I think it's always wise to touch base with your oncologist. Now, if you did some crazy workout and are having some symptoms, I mean, give it some time for it to heal and then call us. But, again, with the new cough, shortness of breath, right? If you just had COVID and you've got a residual cough, you don't need to call the oncologist about that, right? You probably should check in with the primary care. So I think some of it is just, you feel your way through it. Certainly there's never any harm in calling the oncologist and having us tell you, you really should touch base with your primary care. And we do that a lot with patients.
Can you speak to specific areas for bone pain that are more common to kind of keep an eye out for?
Sure. So if you look at metastatic breast cancer patients where they have their bone metastasis, it's typically more centrally located. So neck, back, ribs, pelvis. It's very unusual for someone to present with ankle or knee pain that's a metastatic site. So kind of those more distant wrist, elbow, knee, ankle, those are very unlikely to be a recurrence. But if it's really more centrally located, that's typically where people present with the symptoms. So that, I think, would be a red flag too. If you've got a knee injury, probably go see the primary care, the orthopedist. But if you can't put weight on your hip, you need to call me, right? But I think most patients are kind of somewhere in between, and that's where I think certainly calling your doctor to get advice is the right thing to do.
Yeah. And you've touched on this a little bit about common metastatic sites, but are there any specific to triple negative breast cancer survivors should keep an eye out for versus other breast cancer subtypes?
So patients with triple negative breast cancer typically have less bone only disease. That you see more frequently in patients with hormone receptor positive breast cancers, but certainly you can have bone only disease for triple negative, but they more frequently have liver and lung metastasis or lymph node metastasis. So certainly if you feel any lymph nodes in your neck or, in your axillary region, anything that seems unusual, you should get it checked out.
Thank you. All right, Dr. Stan, I'm a 20-year survivor, stage 3, grade 3. How do treatments affect long-term ear and eye health, or is that just a factor of aging?
Yeah, I saw that question, and I'm not aware of side effects to the eyes, except if you're estrogen positive and you take tamoxifen, that can cause some cataracts. I'm not sure about chemotherapy. Maybe I'll defer that to Dr. Zelnak, but again, I don't think it's related to the treatments from breast cancer, these symptoms necessarily.
Okay. Thank you. All right. I am 79 years old and I had a bilateral mastectomy after a triple negative diagnosis. Will chemo do more harm than good because of my age?
So this goes back to, I think, something, that was mentioned earlier, where patients with triple negative breast cancer often have their recurrences early. And so if you are a 79-year-old patient that's fit and in good health, where you're anticipating that you may potentially live for another 10 years or longer, if you have a triple negative breast cancer recurrence in those first couple of years, that's likely going to meaningfully impact your survival. So I do think that as patients get into their late 70s, early 80s, you have to carefully consider the pros and cons of chemotherapy. Certainly, the health or the fitness of the patient, the extent of the disease. So certainly some of our young triple negative patients, we're giving chemotherapy for an 8mm tumor. I don't think you would do that at 79. But if you've got lymph nodes that are involved or a bigger tumor, I think even at 79, it's reasonable to do it because it has the potential to meaningfully impact your survival. You do have to think carefully about using an anthracycline with the cardiac risk associated with it. Some patients that are older have more issues with the peripheral neuropathy with the taxanes. So you do have to carefully weigh things out. But ultimately, you don't want to have a recurrence because that's going to be difficult to treat, whether you're, at 79 or at any age, right? So I think for many patients, it's reasonable to do it. And I certainly have treated patients into their early 80s if they're in excellent health, potentially with a scaled back regimen. I'm not sure, Danielle, if you see something similar up there at Mayo. I would imagine you do. I just had a patient that I shared with one of the oncologists at Mayo who had a recurrence for triple negative breast cancer, and they sent her back to Atlanta to get her chemo locally. So, I mean, I think, you know, each case is a little bit different. She had declined chemotherapy earlier, but when she had the recurrence, it was local recurrence. It was full steam ahead. So.
I agree. They look at each patient individually, depending on the medical problems they have, and they may de-escalate the treatment to some degree, like Dr. Zelnak mentioned, maybe avoid the anthracyclines and do the others.
Got it. Okay, thank you. So another neuropathy related question. So this person has neuropathy in her feet, no pain, but seems to be getting worse and having difficulty in moving her legs. Is that a common kind of impact of neuropathy? And how would you think about treating something like that?
So most patients that have peripheral neuropathy from the taxanes or from some of these other drugs that cause neuropathy, it's typically sensory. But I think there is certainly, not as frequently observed, but there are patients that have motor dysfunction related to the drugs as well. I think there's ongoing research trying to evaluate this. I have a patient right now, she's on eribulin in the metastatic setting, and she's just had really terrible, really more motor neuropathy issues. And it got better when we held the drug. I mean, that was really how we've managed it for her, is dose reduction and, dose delays and things like that. But it's certainly observed. I don't know that we have a lot of good data on how to treat it other than potentially stopping the drug. And I don't usually see it that much in the early stage setting where patients are getting a defined number of treatments. It's typically in the metastatic setting where patients are on drugs for longer that you see the motor issues develop.
Yeah.
Yeah, I agree. I would want to rule out other possibilities, diabetes and other, vitamin deficiencies, other reasons for neuropathy if it's mainly motor, because it tends to be usually sensory, usually with numbness and tingling. But yeah, about 10%, 15% of people would have weakness. So I don't know that there is a different treatment than what we discussed. Again, some medications and intense physical therapy possibly helpful.
Got it. Okay. So the theme of exercise has come up quite a bit in this group in general and during this conversation tonight, and specifically exercise during chemo, exercise after chemo. Sometimes, though, we battle fatigue and, just kind of general tiredness. So what are your recommendations on specific exercise that might be a little bit more manageable for somebody who's going through chemo?
I think everybody comes to chemotherapy with a different fitness level. So I think that has a huge impact on it. I tell people all the time, if you weren't, running every day during chemotherapy is probably not the right time to go start doing that. I mean, it's you're already going to be fatigued, but certainly I think if you were an avid runner or doing regular exercise, you should continue to do that as long as you feel comfortable. I think for many patients, the stamina takes a hit during chemotherapy. So, what you might usually do with no problem is more challenging for you, but even just keeping that up is really important. After the chemotherapy is finished, I think that's probably a better time for people to start trying to get back in shape or trying to get their weight down if they weren't already. I don't know, Dr. Stan, do you have any comments as well?
Absolutely. I love the topic of exercise, and I try to address it with most of my patients, I want to say. Of course, not everybody's ready, but I think it's so important to try to exercise. And if that's 5 minutes a day and goes up from there, that's just fine. I think it's just making the habit. It's because exercise was shown in many studies to actually improve the outcomes from breast cancer. It improves survival. So I think that's the main goal that we are all after, but then improves all of these symptoms we were talking about, the fatigue included. So it's a vicious cycle. So even if you're fatigued, I think it's good to just go out for 5 minutes or do a yoga or something gentle for 5 minutes, and then increase that to 10 minutes. So as much as you can, and be in the nature, try to get your brain to settle. All these things seem to help the brain with that fatigue that everybody has after the treatments. Even if they didn't get chemotherapy, it seems that the fatigue is a big issue. Probably the stress of going through the surgery, through the discussion what to do. So I think just a regular exercise program is important. Start small and go from there, whatever you can do, and make it part of your life so it becomes a habit. And then, of course, watch the diet. The weight seems to impact to some degree the outcomes from breast cancer as well. And again, exercise helps with the chemo brain, apparently, with the neuropathy. So all those things make it better. So I think it's very important.
Yeah. And you bring up a point that we've discussed in this group as well multiple times, is weight and weight post-treatment. Everybody understands that is a really important factor, and potentially a kind of a long-term survival indicator. But we've also kind of bemoaned the fact that it's difficult to lose weight after going through chemo, after going through kind of temporary menopause or permanent menopause. Do you have any kind of tips or tricks on what people in the group might be able to try to be successful there?
I want to say real life is tough, and even if we discuss it, it's very hard to implement in real life. And I try to do that every 6 months when I see my patients, and probably it happens in 20% of people. They're going to be successful with significant success. I had a 70-something years old lady from Colorado that she was sedentary. She came, we kept talking about exercise, and one day she comes and she's in great shape, and she's doing Zumba Gold, and she's doing it every day, and she's amazing. So I did not expect that from someone like that to make such a big jump. Most of the people are in the middle. They may exercise a little bit, but it's a huge effort. I think it's just making that commitment that I'm going to be disciplined, and I'm going to try to focus my priorities towards this goal. I mean, everybody's so busy, but I think you have to take from one part of life, sacrifice that, and focus on things that are important to you. So I feel that people who are successful make it in a way a priority. They say, okay, I'll take care of myself. I'll have this hour a day where I'm going to be healthy. So I go home after work, or if I'm a morning person, I wake up and I have that hour where I'm going to exercise. And if I'm tired, I'm going to do yoga. If I'm not tired, I'm going to do something intense. So give yourself that flexibility to allow yourself to choose. That's how I feel it works for some people. But just be consistent about it. Try to do it every day as much as possible, and make yourself a priority. I feel that probably gets to some goals success.
Thank you. All right, so we have a question about lymphedema, both preventing lymphedema and then managing lymphedema once somebody has it. Thoughts on that?
I can speak to that briefly. Yes, that's a big issue, especially with axillary dissection, especially with axillary radiation. If lymph nodes were involved, we usually send all our patients that had axillary dissection, meaning removing all of the lymph nodes in the armpit, to the lymphedema clinic to try to educate them on how to prevent lymphedema. And part of this program is a recommendations to actually use weightlifting to prevent lymphedema. So it's a gradual type of exercise. So we tell the people that weight strengthening exercises are important, but you have to do it progressively. And then, of course, fitting with sleeve for lymphedema prevention. They talk about massaging and things like that. And then treatment when lymphedema is established. Again, the lymphedema therapist can advise on different modalities, but wearing a sleeve, massaging techniques, and again, continue the strengthening exercises seems to be important. Weight, again, is an important factor there as well. Seems to people who are overweight, they have a higher propensity to lymphedema, and sedentary people, so exercise again.
The two themes.
Yeah, I was going to say early intervention is key. So I know, like Dr. Stan mentioned, typically patients should be evaluated by lymphedema specialist early on. And I know here at Northside, we're now starting to send people even before surgery as opposed to after surgery, just so that they have the education that they need, the exercises, how do they really, assess and prevent the lymphedema from setting in? Because once it's there, it's more difficult to manage.
Okay, so this person has stage 4 metastatic breast cancer to the spine and ribs, presently on capecitabine for 3 years. And she's triple negative and is curious what other chemotherapy or immunotherapy options might be available to her.
Sure. So thank you for submitting this on the chat. We have some chat people, right? You're doing fantastic on the capecitabine. That's great that you've been on that for 3 years. So as I mentioned earlier, the pembrolizumab is approved in the first line setting for patients that are PD-L1 positive. So that at this point, that's really the only place where a PD-L1 positive patient's treated differently than someone who's PD-L1 negative. So typically you would start with a chemotherapy agent. In your case, you started with capecitabine, probably because it's oral and it doesn't cause hair loss, and in general can be, fairly well tolerated without, having people chained to the infusion center every week. Once a patient progresses, at that point, you sit down with your oncologist and decide which treatment option makes the most sense. And there are a number of drugs that are approved for metastatic triple negative breast cancer. Typically you would use one as long as it's working. And then when your scans show disease progression, that's when you switch. And I think each time you switch, decisions are tailored based on your prior treatment, what toxicity you've had. So we spent a good bit of time talking about neuropathy. Well, if you have really terrible neuropathy after you've received Taxol, I'm not going to give you Eribulin next. I'm going to potentially give you a different drug that doesn't cause the peripheral neuropathy so that you can have a break in there. One of the newer drugs that's been approved is this called sacituzumab govitecan, or Trodelvy. That's probably the newest drug that was specifically approved for triple negative metastatic breast cancer. And the data there has shown excellent responses, even in patients that have chemo-resistant disease. That drug is also being looked at in patients with ER positive breast cancer. So it's approved for triple negative. And then the large randomized trial looking at ER positive, HER2 negative patients has been, accrual has been completed, but we're waiting on the results. So that drug may be used for other patients as well. But there are multiple options. I mean, I think, patients get Eribulin, they get gemcitabine carboplatin, they get the SASI drug I just mentioned, vinorelbine. I mean, there's just a bunch that we'll end up using, to help control the disease over a period of time.
Got it. And then just back to the immunotherapy options briefly. You mentioned the PD-L1 option. What about an immunotherapy option for somebody that does not have PD-L1?
Outside of a clinical trial right now, you're not going to be able to get it, typically not going to be able to get it covered. Now, some of the genomic profiling that you may do, sometimes patients have higher, tumor mutation burden. They may have some other indication that immune therapy may be helpful beyond the PD-L1 testing. So that's where, your medical oncologist may, appeal to your insurance company to see if it'll be covered. But typically right now, it's just for the PD-L1 positive patients.
Got it. All right. And while we're talking chemo, a question that was submitted in advance: do cancer cells build resistance to chemo treatments, and kind of what does that mechanism, and how do you understand that?
I think there are a couple different ways to look at this. Like, one question is, were the cancer cells always resistant? And over time, the chemotherapy worked against the cells that were less resistant, and then what remains that didn't get treated then has an opportunity to grow and flourish. So I think there's some data that would support that. I think the other option is that, well, did the cancer mutate or change over time that then promotes the resistance? And I think there's probably a little bit of both. There's been some really interesting studies done primarily up at my alma mater, Chapel Hill, where they've done some studies looking at patients, looking at the profiles of cancers or the different tumor sites. So, let's look at the mutations in the lung and then in the brain or in the different places. And I think this idea that the cancer is uniform throughout all of the different sites is really not the right way to think about it, right? They're different, branches of the tree, so to speak, where, the cancer is different, and they're different clones. Do you know what I mean? When you think about that. And so I think that has some impact on the chemo sensitivity over time. So it's hard to know if you're just selecting for the cells that could survive, or if it's promoted, or promoted may not be the right word, but caused by some of the pressure of the chemotherapy causing changes.
Got it. Okay, thank you. And then we have a question in the chat. What about fingernail and toenail issues after chemo?
So this happens primarily for early stage patients with the taxanes, and it can be real, right? Anecdotally, I think I see it a little bit more with docetaxel and nab-paclitaxel than I do with regular paclitaxel, but it can happen with all of them, where typically the nail beds can start to lift up and, kind of, what's the right word? The fingernails get a little nubby. Now, I'm not using medical terms, right? You can Google taxotere nails and see some pictures. Typically, those are short-lived, where, once people recover from the chemotherapy, the nails grow back out. The toenails tend to grow a little bit slower. But certainly there are patients that have kind of, their nails just aren't ever quite as strong. And I have patients taking hair, skin, and nails and all sorts of things to try and, circumvent that. But there's not necessarily a way to prevent it. During the chemotherapy, it's hopefully one of those things that's short-lived and then gets better with time.
Yeah. Okay, got it. Dr. Stan, I think that this one falls in your realm about managing anxiety. I think, it's safe to say that a lot of the members of this group have had or do have anxiety about recurrence, or anxiety about the effectiveness of treatment, just kind of all around anxiety. What kind of tips and tricks do you have for helping to manage that anxiety? I know that exercise will be one of those, but what other tips do you have for that?
Yeah, I know that's a tough one. And this fear of recurrence is such a common worry, of course, understandably so. So I think just to separate the real anxiety from the fear of recurrence, I think when we see our patients, a lot of discussion and reassurance regarding how well they do, and give them the tools to empower them actually to recognize symptoms of recurrence, and reassure them that if that comes, we will be looking into it. A lot of discussion goes into why don't we do PET scans and things like that, because that's, again, they think they may get reassured with that study, with that procedure, and we talk a little bit about that as well. So I think just putting their fears at ease, saying if something comes up, we'll address it, so they know that they have someone in you that they can always come back to, and you're going to investigate, you're not going to ignore. So that's how I address the fear of recurrence. The anxiety, if it's related to depression or real generalized anxiety, I treat it similarly to how I treat general anxiety disorder with maybe antidepressant and anxiety medications. We have a very well-rounded integrative clinic here, thankfully, and a lot of our patients like to go into the stress management classes. That can be also individualized with stress management, doctors that see them regularly. So those who don't want to take medications, we go that route. Yeah. If I don't want to get into the exercise and the yoga, but those seem to help with that as well.
Yeah. All right, great. Well, I'm getting some private questions sent over to me in the chat. So Dr. Zelnak, you talked about, at one point we talked about standard of care, and then at one point you touched on kind of more personalized treatments, or the ability to kind of discuss the various treatments. What do you see on the horizon for triple negative breast cancer, especially early stage triple negative breast cancer?
So I think that one of the big studies that I want to see is the adjuvant pembrolizumab trial. So that study was set up where patients got whatever chemotherapy they were going to get before surgery. And then if they had residual disease at the time of surgery, they then were randomized between pembro and the postoperative setting versus not. So, one of the questions is always who needs max care, versus can you tailor it? And so, the current approach where the pembro is given in the neoadjuvant setting is, well, you're just going to give it to everyone. Well, for half of the patients, they were going to have a complete response with just the treatment without the pembrolizumab. So did they really, you can't pick out who had to have it. So, one option would be in the postoperative setting for those patients that didn't have the complete response with standard chemotherapy. Can you then make up the difference by giving it afterwards? So I think for me, that's a study that I think is going to be really helpful. The addition of pembro has also raised some questions about what do we do for patients that have residual disease, because currently before pembro, if a patient had residual disease, they were often given 6 months of capecitabine in the adjuvant setting. But the trial that used pembro, I don't know whether those patients should continue the pembro. Should I be giving them the capecitabine? So I think some of those questions about how to incorporate our current therapy is going to be important. I think one of the other big things for triple negative breast cancer is that, the NCCN, they recently changed the recommendations that all women of all ages undergo genetic testing to look for germline BRCA1 and 2 mutations. It used to be just under 60. And, back when I was a baby oncologist, it was under 50. So they've gradually upped the age for that. But that's critically important too, because the use of an adjuvant PARP inhibitor, so 1 year of a drug called olaparib, has also been shown to impact recurrence rates for those BRCA1 and 2 mutation carriers. So you don't want to miss those patients. So I think it's really important that people have the genetic testing done, because those drugs have been shown to impact recurrence rates. But if you don't know someone's BRCA positive, you don't even know to recommend it. I think the other thing I would say, it'll be interesting to see the drug sacituzumab govitecan that's been, very successful in the metastatic setting. There certainly are trials ongoing looking at incorporating that into the early stage setting, both in this context of I had residual disease after preoperative chemotherapy, so I didn't quite get across the finish line with the standard of care, but then also incorporating it into neoadjuvant chemotherapy. So I think that's, at least from my vantage point, the main things that'll be potentially practice changing here in the next little bit.
Thank you. And then similarly for you, Dr. Stan, what kind of research, what are you seeing on the horizon of side effect management in the future?
Yeah, I think, the guidelines on side effect management change all the time. Things that worked before, they are taken out, and the other way around. So I would just probably hope to see more of the overall integrative approaches to this side effect management in the main oncology practice. I would like to see the person maybe seen as a whole and see how we can address both psychological issues and physical issues. So yeah, that's my area that I'm interested on. And like Dr. Zelnak said, I also wanted to mention the BRCA or actually the whole genetic panel testing that we actually recommend here for everybody. Prior to age of 65, we test everyone that has breast cancer, regardless of family history, just because we miss a lot of people. If they don't have family history, they don't go to get tested. So now we test everyone. And I think in the triple negative, that makes a big impact.
How often do you recommend people go back for genetic testing?
So we actually have a system in which they are being seen at the time of the diagnosis, and if they tested negative, they are being told to call the medical geneticist every 2 years to ask if there is something new. Because just recently we changed it from doing the BRCA gene mutation and then the 9 gene panel. Now we do 23 gene panel, so it changes often.
Yeah.
I think typically our genetic counselors recommend that you check in every 5 years or so just to see if there's been significant changes in testing. And that sounds about right. I know certainly the testing, if you had it in 2015, you may need to go get retested because there's just more patients that we're identifying. Sometimes you find variants of unknown significance or mutations in genes that we don't quite know what to do with yet. But that information may be helpful for the future for your family to know.
Yeah.
And even if you were diagnosed 15 years ago, you can still go and get tested now because you would fit into the criteria by these days criteria to get tested if you were less than 65 at the time of the diagnosis. Yeah,
great. Okay, thank you. All right, we've got about 3 minutes left, and there is a question in the chat. Chemo recommendations for a person who was hormonal positive for 3 years before mutating to triple negative in the past 2 years. Chemos so far have been Xeloda, Ibrance, letrozole, paclitaxel with Herceptin, and pertuzumab, Doxil, Trodelvy, and just starting Ilrubin. Sorry,
sure.
I butchered that.
So I just sent her a direct message, but we'll respond as well. I think certainly Eribulin would be a good choice for someone who's triple negative. Typically patients would see a platinum at some point as well. So the regimen of gemcitabine plus carboplatin. I think she'd asked as well about Enhertu, which is trastuzumab deruxtecan, which is a immunoconjugate drug that's basically Herceptin or trastuzumab with chemo attached to it. That drug is currently only FDA approved for HER2 positive breast cancer patients. So if your last biopsy showed triple negative disease, it wouldn't make sense to use that. They do have studies that are ongoing in patients that have HER2 low disease. Those trials, I think, have shown some promising efficacy, but it's not currently approved for patients that aren't HER2 positive. But certainly there are other chemotherapy drugs that you could use as well. Vinorelbine would be one, and I'd have to think through, but there's several options out there. But Eribulin for now sounds like a good choice. And then Gemcarbo is probably what I would do next.
Thank you. All right. Well, we are right on time. So it's almost just under 7 o'clock. So thank you both so much for this conversation and for answering all of our questions. I thought that it was really fantastic and appreciate you both taking the time to speak with us this evening. So I took a ton of notes. I'm sure everybody else did too. Thank you again. And thank you all for joining. We will be back the 3rd Tuesday of October.
Thank you for having me.
Yeah, thank you. Everyone have a good night. Stay safe.
Thanks. Have a great night.
Bye.
Bye.